Okay, we'll just maybe start with some very quick presentations or introductions to ourselves. I'm Erin Mahalik. I'm a professor at UBC and lead for the Patient Engagement Methods Cluster. Anita, you're next to my right.
Oh, okay. So I'm Anita. I'm the co-lead, the patient partner on one of the engagements that you'll be hearing about in our presentation.
And Lynn.
My name is Lynn Chen. Good afternoon, everyone. I'm the other patient partner co-lead for the Tapestry project and looking forward to sharing our learnings with you all.
Thank you, Lynn. And
Iva. I'm Iva Chung. I'm a postdoc on the Tapestry project, and I'm coming to you from the traditional ancestral and unceded territory of the Kootenay First Nation. Hey, should I share my screen?
Yeah.
Okay, let's do that. Oh dear. Okay.
It's just slow.
Can you see my screen now?
Good. Yeah.
Okay. I don't think I'm going to be able to play the sound on the video, but that's okay. We're not going to spend too much time on it anyway. All right. So let's start off with project background. That's you, Erin.
Thank you. And so those of you who are familiar with the work that we've done in the last 3 years in the Patient Engagement Methods Cluster will know that it's been similar but different to the wonderful work that's been done in all of the other methods clusters. We've all gone through a detailed and diverse method and process for engaging with various stakeholders about the very areas that we should be focusing on supporting in our specific areas. For us, that involved a series of interviews, one-on-one interviews, an online survey, and some digital methods like a tweet chat and an in-person visioning workshop. Next slide, please. And the result of all of those consultations was fairly clear. We understood that there was a major overarching theme or umbrella, which is really guiding the work ahead of us, which was the need for us to coalesce around advancing and embracing diversity in patient engagement and research in British Columbia. Our project that we're showing you today is one element of the Tapestry project, which really had trifold aims to fill gaps in resources for engaging with specific underrepresented communities in British Columbia, to help both researchers and diverse patient partners to develop new relationships and to sustain those relationships over time, and to advance patient engagement research methods to support engagement with diverse groups. Tapestry platform was developed and is the brainchild of Dr. Stephen Barnes originally. He is a professor in psychology at UBC and the co-lead on this project. We were in a meeting with him yesterday or the day before, and he described how it came about in his head. And he said he was on a camping trip and sitting there thinking that the way he teaches was always linear. And he realized that the way he thinks is very non-linear, and that there are problems in the way that we teach, in that it's often didactic, it's often from the educator to the learner, and that a new model of learning and sharing information, which is multi-directional and interconnected and non-linear, would be a different way of looking at things, a different way of educating and sharing knowledge. So the Tapestry platform does just this. It was made to produce video content primarily, but really any kind of audio, text, visual content can be integrated into the system. Next slide. And this is an example of just one of the modules that was created with a UBC Teaching and Learning Enhancement Fund grant before we became involved in the support unit. That one was developed to look at intercultural understanding. Over to you, Ivan.
Okay, thanks. Thanks, Erin. So when I joined this project, I knew we would be making 5 of these educational modules on the Tapestry platform, and 4 of them would be co-created by teams representing certain priority populations. We just weren't sure exactly which ones yet. So our first step was to do an environmental scan. I should say that at the very beginning, we already knew that we would be doing one for the LGBTQ2S+ communities, but we also wanted to identify other priority populations for our other 3 modules. So our first step was to do an environmental scan. So to look online and offline for existing resources that would support research teams to engage diverse patient partners. So we did this for 2 reasons. One is that if a good resource already exists, then we don't want to have to reinvent the wheel. We could just share that resource. The second reason is to do this environmental scan is to find the gaps and see clearly where we would have to provide these resources and the support. So from that scan, we chose our first 4 priority populations. As I mentioned, the LGBTQ2S+. The communities had already been identified, but we also added the deaf and disabled communities, the immigrant, refugee, ethnocultural, and racialized communities, as well as rural and remote communities. These are by no means the only communities we'd like to hear from, but these give us a starting point. So in addition to the modules for these 4 priority populations, we also have one overarching primer module that deals with a lot of the common issues that research teams might run into when engaging underrepresented populations. So to put together our teams, we put out a call for team members late last fall, and each team started off with 1 or 2 patient partners, as well as an academic co-lead who's a member of the priority population. We have a blog post introducing our team members if you'd like to find out more about them, and I can put that link in the chat in a bit after I'm done talking. And teams are responsible for creating the content. They developed the first draft of the video scripts, and they have project management, editing, and video production support. So our aim was to create short videos, a few minutes each video tackling a specific topic, and getting a total of about 15 to 20 minutes of content in each module that's made up of several videos. So beyond these individual teams, as I mentioned, we do have a primer module that addresses some of the fundamentals of patient engagement and research and diversity in patient engagement and research, why we need to increase diversity, the various barriers we faced and that diverse patient partners face in engaging. And we've taken a very intersectional approach. So these primer nodes, these videos, they give a little bit of a historical and theoretical understanding of why things are the way they are. So why underrepresented groups might be reluctant to engage in research. And if you were at the previous plenary, you'll have encountered the idea that there has been harm done to these communities. And as a result, we have to acknowledge that harm to move forward and understand why they might be reluctant to engage. But in addition to these sort of theoretical and historical contexts, we also wanted to give people very practical advice that they could use right away. So I don't think the sound is going to play on this, but this is just one of our, oh, can you hear that? No. Okay. I can hear it, but the audio is not coming through. But this is for our primer module. And it's just a short snippet to show you what our primer looks like. And this is from our video giving people tips about what the first meeting, when they're first engaging patient partners, what that meeting would look like and what considerations you might need to work into that meeting. So as you can see, it's very visually driven. So in the interest of time and the fact that you can't hear the audio, I'll just stop it there. But I wanted to give you an idea of the process so far. So we have the primer module and the 4 priority population teams. Each team has chosen its own way of working together. They've also chosen their own content, although there are common themes running throughout. And each team has its own aesthetic as well. So we'd initially envisioned 15 to 20 minutes total of content in each module, but we're finding that we're running closer to 30 minutes because there's just so much to say. At first, we were hoping to make these educational modules for research teams, so academic researchers as well as patient partners coming into the relationship. But what we discovered really was that the people needing the education were actually the academic researchers. So they were the ones who actually needed the information. And it wasn't really about providing education to patient partners. It was about giving academic researchers this context to understand why underrepresented populations happen to be underrepresented. So this is just to show that this is a snippet from our LGBTQ2S+ module, just to show you that there are different aesthetics. As you see from our primer that I showed earlier, it was like a paper cut stop motion animation, and this crew decided to go more in a talking head explainer video. So each team has its own way of working and its own aesthetic. Okay, so I will turn it over to Lynn and Anita to talk about their module.
Thanks,
Thank
Iva.
you.
Go ahead, Lynn.
Yes, thank you, Iva. So my name again is Lynn, and as one of the patient partner co-leads, I wanted to share briefly about how it is we went about choosing content. So we initially started to think about the research cycle and how this population of immigrant, refugee, ethnocultural audiences has and has not been involved in patient-oriented research, and realized quite early on that this importance, this issue, prevalent issue of engaging early and often also is reflective of this group as well. So as such, we shifted then our approach to content development toward topics specific to keep in mind in working with and engaging with this population. So these are the following topics that you'll see eventually as Tapestry modules. They include engaging and recruiting patient partners, working across language barriers and with interpreters and translators, trauma-informed practice, cultural safety and humility, and knowledge translation.
Right, now this is just a small clip of what our video looks like. So basically it's patient partners that have had experiences, and the researchers are now open to working with them to finding solutions. The door's not supposed to close, it's just looping, so just so you know. Excellent. And one of the things that was really important to the success of the project at the co-lead level was it was really important for Lynn and I to get a chance to get to know each other, and that was bringing together our professional experiences, because what we found is we came from unique backgrounds, and we were able to find a lot of strengths in the other person. And we really drew on that as a team. We had a lot of open communication. We started each meeting with a bit of a check-in, and then we would move into our work. We worked closely together since, I guess it was end of January. So we've managed to really build on our relationship and our communications. And again, finding each other's strengths, and because we've worked together for so long, and I know that there's something that she could explain better than I could, I would give her the space to shine. And
Okay, ladies, we seem to be having an audio problem with your presentation, but in any event, we need to move on to the second presentation.
Okay, I'll stop my sharing.
Thank you. So our next presentation is the Patient Experience and Outcomes Surveys for the Kootenay Boundary Primary Care Network implementation. And I would ask if there's anything from each of these sessions that's missed, if you would post any access or videos or anything that you have on the chat box. Thank you. Go ahead.
Thanks so much for having me here. I'll start sharing my screen and hopefully it'll work. And then I'll just put it on slideshow. So I think we're good. Everyone can see my screen. Great, wonderful. So as part of our primary care network implementation in Kootenay Boundary, which is a small rural region in southern BC, we wanted to do a patient experience survey. So just a little bit of background on our region. It's pretty rural. We have a population of about 80,000, and we're a Wave 1B primary care network region. We have 13 clinics that are participating in our primary care network, and we're integrating nurse practitioners, nurses, social workers, and physiotherapists and occupational therapists into clinic teams to try to provide better services to patients. So the purpose of our survey was to gather baseline data to better understand the impacts of PCN implementation, but also to really provide information to help us implement our PCN, to really understand patient needs better and try to inform our clinics of some of their needs in advance of implementation. We started with the Alberta PCN Patient Experience Survey and the US Consumer Assessment of Healthcare Providers survey, and added some questions. And then we ran it through our Patient Advisory Committee and our Aboriginal Services Collaborative for feedback. So they both had significant feedback. The Patient Advisory Committee in particular spent a couple of sessions reviewing it and providing a lot of detailed input on the questions they thought would be most appropriate, as did the Aboriginal Services Collaborative, who tended to focus a little bit more on the cultural safety questions. We produced 3 versions, an attached patient long version, a short version, which was about half the length. We wanted to try and make it as accessible as possible, and a version for unattached patients, so those patients who didn't have a primary care provider. Interestingly, we found that most patients chose to complete the long version despite having the option of doing the short version. We had it open for 3 months. We publicized it in multiple ways. We had paper copies with stamped envelopes and cards available in all clinics. We put them up at pharmacies, which was a great way to attract patients. Pharmacists actually did some great outreach for us. And we also reached out to social service organizations and paid them, made donations and paid them honorariums to help try to get more marginalized or lower socioeconomic status patients to complete the survey. And that was actually fairly effective. Some of the social service organizations we reached out to actually sat with patients and helped them complete it if there were language barriers. So it was a pretty effective way to try to make sure we were reaching as diverse a population as possible, given the limitations that we had, which were not being able to translate it into multiple languages. We also did Facebook publicity. So there was an online version of the survey and paper versions of the survey. We wanted to produce a number of analyses and products, regional reports to help our PCN steering committee plan for PCN implementation. We gave individualized clinic reports back to each participating clinic so they could see where they scored relative to the other clinics in the region. We produced focused reports on specific patient populations. And we also did a public report back to patients, which is being distributed via Facebook on our website and in clinics, because it was really important to acknowledge the critical contribution of patients to the learnings that we gathered through the survey. I I won't go too much into the details of the findings, but it was a volunteer survey, so it wasn't a random sample. So we did have a pretty good response rate with over 1,500 responses. We had a much higher proportion of females that responded than males, so 79%, and a higher proportion of people over the age of 65 than would be expected. People over the age of 65 are about 20% of our regional population. But we were fairly happy with the response rate, but every time we look at the results, we have to keep in mind that it was not a random sample and that there are certain populations that were more represented than others. We measured a variety of things. Urgent access, we found that 38% of patients reported being able to get a same or next day appointment, and 53% indicated that their wait times for urgent appointments was acceptable or very acceptable. 49% of patients were able to get a routine appointment within 7 days, and 61% found that that was acceptable or very acceptable. Apparently I can't advance anymore. We also looked at the number of emergency department visits generated when, this is patient self-report, emergency department visits generated when they couldn't access primary care. So when they called and couldn't get an appointment, or when their primary care clinic was closed. And we found that there's about 1 visit per year generated per patient for attached patients, and about 1.4 visits per year generated per patient for patients who don't have a primary care provider. 32% of attached patients reported that they forewent care, is that a word? They foregoing care when they could not get an appointment, and 51% of unattached patients reported foregoing care because they could not access care when they needed to. The quality of care measures were pretty high overall. You can look and see across this bar chart that 90% of patients, over 90% of patients for most of the measures said this happens to them always or most of the time. So things like their care team having access to results or treating them with dignity and respect. The lowest ratings were probably related to time. So seeing their primary care provider within 15 minutes of their appointment time and having their primary care provider spend enough time with them. They were lower for certain populations, and they were definitely much lower for unattached patients. Unattached patients in general reported having a much more difficult and felt they experienced lower care quality in the system. These are just another set of quality of care ratings. I won't spend too much time on this slide. So overall, 74% of attached patients rated their clinic as an 8 out of 10 or higher, and 29% of unattached patients rated their primary care experience as 8 out of 10 or higher. So you can see the difference in the experience between attached patients who have a primary care provider and unattached patients. We asked questions about whether patients felt they experienced discrimination at their care clinic, and this was at the direct request of our patient advisory committee and our Aboriginal collaborative, who really wanted to know the results from these questions. We found that 6% of patients indicated that they experienced discrimination, and 20% of unattached patients felt that they experienced discrimination. And these were some of the leading reasons for discrimination. So health challenges, age, views that, provider views that they may be drug seeking, or mental health issues.
Jennifer, I'm just going to ask you to try and wrap it up now, please.
Yes. Okay. So I'll just flash through these last slides quickly. So we also asked about self-reported health, barriers to health. We asked unattached patients to tell us more about their experiences. And we also asked qualitative questions about what is great about the care that they receive and what is not so great. So in terms of, one last slide, in terms of what is not great, wait times for appointments really emerged as the #1 thing that really concerned patients, and not being able to change doctors if they want to. And then doctors or not nurse practitioners not spending enough time with the patients. Those were the top 3 qualitative comments that we received. And I will leave it there.
Thank you, Jennifer. If you have any information that you'd like us to be able to review, just attach it in the comments section, please. So thank you very much for your presentation. Next, I know this time is compressed, folks, and I do apologize. Our next presentation is Stronger Muscles Start with Stronger Partnerships, Evaluating the Patient Engagement Process Using the Patient Engagement in Research Framework.
Sorry, I'm notorious for long titles. So Eileen Davidson and I will be co-presenting, and maybe Eileen, if you just want to introduce yourself first. And
Hi, my name is Eileen. I'm from Vancouver. I am a patient advocate. I partner with Arthritis Research Canada on their patient advisory board, as well as a patient engagement research ambassador with CIHR IMHA. It's a pleasure to be here today. Thank you.
And before I begin, I also just wanted to acknowledge our collaborators on this project. So Hattie Shoes, an undergraduate student who worked with us, our Arthritis Patient Advisory Board, Eileen being one of our members, along with Sadiq, Karen, Luella, John, Shannon, who's on the line here today, Allison, and of course, Dr. Linda Lee. So before we get into we're really going to talk about our patient partner engagement process, but just a bit of background on the research project itself. So our project focuses on how to support people with rheumatoid arthritis specifically to participate in more strength training, and to also look at how we can move beyond these one-size-fits-all physical activity interventions to more tailored approaches. So we see there are a number of different phases to this research project, but the important thing to note here is that our Arthritis Patient Advisory Board, or APAB for short, have been involved at every step of the process. So APAB, or Arthritis Patient Advisory Board, consists of a membership of people living with arthritis who collaborate with researchers at Arthritis Research Canada on a number of different projects, and we're lucky to have them on board with our iStart project. So we're talking about patient engagement here, right? And we know that, evidence is mounting and the importance of patient engagement, improving the relevance and the impact of our research. But what we're really trying to get a hold of is how we can best involve our partners. So maybe Eileen, if you wanted to share a little bit of your opinion on why it's important to make sure that, not only that we do patient engagement, but we also evaluate it.
Evaluation is needed to understand impact, where improvements can be made, whether your partners are actually happy. It's motivating to feel like you're supported. And so why is it important we evaluate our patient partner process? The important thing is to make sure you are keeping relevant to what the target patient population's needs are. And it's a great way for you to learn and grow, and making sure that your research is actually benefiting the patients.
Yeah. So we kind of have this opportunity for a two-way street here when we evaluate our partnership. Now, Cleon Hamilton is going to blow me out of the water for talking about the patient engagement research framework. So I'm not going to go into great details here because you'll hear from him next. But the patient engagement research framework focuses on 8 key elements for fostering this meaningful engagement. And what I'll point out here quickly is that you can see those that have been involved in the development here not only are scientists and researchers, but we've got knowledge mobilizers, clinicians, and patient partners, some of which are involved in our Arthritis Patient Advisory Board. And again, Clan's going to talk about this, but associated with the PEIR, we also have the PEIRS scale, which is used to evaluate, as well as a workbook that we actually use to help us guide some of our initial conversations when we started our partner project. So what we want to talk about today are 2 things. So one, to give you guys an example of an application of how we can use the PEIR framework, and also present some results on our evaluation of our patient engagement process. So starting with the first one here. So in the beginning of our partnership, we actually held a few meetings where we not only talked about the science, but also talked about our partnership. And so we would ask questions like, what are the sorts of things that you want to, as Eileen mentioned, benefit from this project? how can we make this convenient? Like, what are the logistics of how we can make this work in terms of meeting times, how we meet, how often? How can we make sure that we are providing adequate compensation, you know, whether that's monetary, and oftentimes those conversations that are monetary, we have separately. What sort of phases or areas of the research project are you interested in contributing, and how can we highlight your different skills or perspectives that you bring to the table? Other questions that we were sure to, you know, make sure we have a discussion on is understanding how we can create this environment where we don't feel like there's this hierarchy in either direction. You know, we're all sitting here equal at the table. What are reasonable time commitments? Is a 5-hour meeting too much? Yeah, probably. These are some good procedural requirements that we should discuss. And what are the ways that we can support our partners to make sure that they are able to participate fully? So whether that's through training or other supports. So with those principles in mind, we've now worked over the past 2 years with our patient partners on different areas of this project. And you can see here in the yellow box here that our partners have been involved right from the get-go in defining what our question even is, all the way through to dissemination. But I think Eileen can kind of explain it best on some of the specifics and how she herself has been involved in our research.
So this was actually one of the research studies that I first started off with APAB. So I've been involved right from the very beginning. It's been a very great learning process for me because I've been able to be involved quite extensively from the design to recruitment through my social media channels, which actually recruited most of the people to be involved in it, which was quite nice to find out, to be involved in focus groups, co-presenting at a number of conferences like this one, but most notably at the American College of Rheumatology last year, which you can see the photo of us there. And then I am also a blogger with Creaky Joints and my own blog, Chronic Eileen. So I was able to kind of take what I learned from Jasmine's study and put it into a personal essay that I write about with rheumatoid arthritis. So it was a great collaboration for researcher and patient to work together.
Yeah, especially on, I've got to say, on the dissemination side, Eileen has shared so much of our work along with our other partners. You know, if you want the best ways to get our research out there, our patient partners have totally led the way on that. I
will link that article right now too.
Yeah, thanks, Eileen.
2-minute warning, ladies.
Okay. So our second piece here in sharing our results and our evaluation. So we not only evaluate using the PEIRS scale, but as well as our interviews. And so with the scale, just briefly here, quantitatively, we're seeing that our patient partners ranked us quite highly in our patient engagement process. But the meat here is really in, you know, what were the things that we did to target these components of the patient engagement research framework? So some examples are making sure that, you know, when we have deadlines, providing reminders, thinking about the right ways to communicate. For some, it was through phone, others it was email, giving different opportunities when we meet to meet in person versus video conference, right? A number of our patient partners are actually co-authors not only on conference abstracts, but on manuscripts as well that are either under review or just being finished up right now. Looking at different ways to contribute, right? Understanding that, you know, there are different areas in which folks are interested in participating. So having a Google Doc to help sign up. And then just for the sake of time here, if it's all right with you, Eileen, I'll move on from this one and just we'll share this little bit here. And one of the key things here is understanding that when we have these conversations, when we facilitate meetings, is when we're hearing our patient partners contribute, is that we're also summarizing and reflecting on what we're listening to. Providing adequate time to review. You know, you would never ask your supervisor to provide you feedback on a grant 2 days before it's due. Pay your partners the same respect and give them adequate time to review. And also lastly here is that our patient partners share so much of their expertise, looking at the different ways that we can also give back and sharing our expertise. So for example, in addition to my role as a researcher, I'm a kinesiologist, and I've developed strength training programs and exercise videos for our patient partners. So to wrap things up here, Eileen and I just wanted to share perhaps our 3 take-home lessons learned here. Eileen, I'll pass the buck to you to start.
Okay, so I think it's really important that you understand every patient has something to offer, whether it doesn't matter what career we have, we all got something that we struggle with the disease every day, and we can offer you so many different understandings of what it's like to live with the condition. And one of the things I really admire about Jasmine's communication is that she is always reflecting what I'm listening to, so it feels very validating as a patient to hear that reflection. And if you want to be a good partner, I think the best thing you can focus on is communication.
Yeah. I think with that, you know, one of the things that I really appreciate about Eileen and our other patient partners is that they play so many roles outside of their experience and expertise in their disease, right? Like we have, you know, Eileen's a quite famous blogger, but we also have, you know, folks that have a PhD in geology, you know, work in IT science, or professional athletes, clinicians, like just a wealth of other experience that we can really, you know, tap into beyond just their experience as experience with their disease. So the last one I'll leave you with here, the point is,
Jasmine, I'm going to cut you off here.
Okay.
I'm sorry. I'd like to leave
No
a few minutes for questions for anyone. So thank you very much, both to you and to Eileen for your presentation. So our next folks that are up are speaking on measurement properties of the short form patient engagement and research scale. So thank you very much. Take it away.
Welcome, everybody. I'm Shannon. I'll be doing the first part of the presentation. I'm one of the patient partners, and Cleon will take over.
Is my slide, are
your slides up? Yeah. Did you want to go to your screen's up, but you need to put your slide present. There we go. Perfect. So next slide. This is our team. So we have Dr. Hamilton, Dr. Lee, myself, Annette McKinnon, who participated from Ontario, Kelly English, and Allison Hones, and our collaborator was Dr. Lisa Hawk. So the rationale for creating new PEIRS was to create a tool that would help to move beyond reflective narratives to test and identify effective methods for meaningful engagement. To improve the quality of partnerships on individual research projects and the quality of partnerships across research networks. Access correlation between research outcomes and the quality of patient partner engagement. Next slide, please. Recognizing the need for a conceptual basis for measurement of meaningful patient engagement in research. In 2017, we published a conceptual framework consisting of 8 key themes and a different definition for meaningful patient engagement in research. This framework was based on the experiences of patient partners and supplemented with published research. Next slide. And you just saw this in the previous presentation. You got a cheated view. Specifically, the themes that define patient meaningful engagement in research projects from a patient partner perspective were procedural, requirements, convenience, contributions, support, team interaction, research environment, feeling valued, and benefits. Fast forward to 2018, we published the original version of the PEIRS from a mixed methods study, and I will turn it over to Cleon.
Thank you, Shannon. So PEIRS is a 37-item questionnaire to be completed by patient partners, including family caregiver partners, to determine their degree of meaningful patient engagement in research. And this is as an indicator of the quality of their engagement in research projects. The items are distributed across 7 sections, which align to the 8 themes in the patient engagement in research scale framework presented previously by Yasmin. Thank you very much for that too, Yasmina. And so users have told us that the scale could be shorter. We also needed to demonstrate the PEIRS scores are valid and a reliable measure. And so in the current study, we sought to shorten the PEIRS to its most essential items and to evaluate its measurement properties. To do this, we collected new data in a one-time online survey of patients and caregiver partners in Canada and in the United States. Some participants completed the survey a second time to enable us to be able to assess the reliability of the scale. We also had a paper-based survey in Canada. All participants were patients or family caregiver partners in research projects within the last 3 years, were 17 years or older and communicated in English. And we use data analysis from both traditional and modern approaches. 119 participants completed the survey. 53 of these 119 completed the survey a second time between 2 to 13 days. 199 were from Canada. They were mainly female, younger than 65 years, and had post-secondary education. Most participants identified as Caucasian white. They were patients and as engaging in regional studies that are currently ongoing. So studies that are in their carrying out stage. We tested each participant's responses, whether it could be combined into a single PEIRS scores. So can we generate a single PEIRS scores from the PEIRS? Our analysis resulted in the PEIRS reduction to a 22 items PEIRS. That was mainly due to low inter-item correlation and some high correlation between items. Our results showed responses to all items can be combined to form a single total score that explains much of the experiences of patient partners on a research project. So we see 55% explained variance. We also found that this score has good reliability and moderate correlation with 10 items of the PPEIRS suggested by questionnaire PPEIRS and PEIRS-22 capturing the patient experience, suggesting that both of these questionnaire capture patient engagement experiences. We also found that there were significant differences in PEIRS scores for people who provided different global rating of meaningful patient engagement in research using a single item score or measure. And I will speak about that a little bit more in a couple of slides. So what we see here on the screen, this is called the Bland-Altman plot. And the results here of the 53 participants who completed the PEIRS twice shows that most of them changes in their scores between these two times were less than 10% of the PEIRS scales. So this is good, as you can see between the two red bars here. So in terms of the correlation with the PPEIRS, which is another measure similar to the PEIRS, but for patients mostly in health services and not necessarily research. As presented 2 slides back and consistent with our hypotheses, the PEIRS scores were moderately correlated with 7 of the 10 PPEIRS items tested. This means that the 2 questionnaires are capturing a similar construct of patient engagement experiences. Here we're seeing, we determined benchmarking scores across 3 levels of global meaningful engagement in research. These three levels of global rating of meaningful engagement were not to moderately meaningful, very meaningful, and extremely meaningful. And we found that the peer scores that were generated at not to moderately meaningful, we had about 73 on the peers. So on a scale of 0 to 100, we found that people with not to moderately meaningful were scoring about 73 or less. And so we think that these scores here in the middle column could be used as a sort of benchmark. The graph here on this slide what was from rash analysis, and it suggests that most of the participants had higher degrees of meaningful patient engagement in research. So patients' experience were typically higher than the baseline of the questionnaire. Using results also from PEIRS, from the rash analysis, we mapped the 22 items onto 3 levels of meaningful engagement. These levels were foundational, which is we also termed bronze level, intermediate, also termed silver level, and advanced level of engagement, also termed gold level. So these were the foundational, intermediate, and advanced level. Patient partners must strongly agree with an item to achieve its level. This could be useful for planning by targeting certain key elements of engagement.
Excuse me, Cleon, 2 minutes.
Yes, so here thank you very much. We are about finished. These are all the questions in the PEIRS 22. They are shown in the minimum level in which they must be strongly agreed with. For example, at the foundational level or the bronze level, we see CN2 opportunities to express one's views. At the silver level, we have receives sufficient project updates. And at the advanced level, we have recognitions of one's contribution. So in conclusions, the PEIRS is a valid and reliable tool for assessing the degree of meaningful patient engagement in research. It enables standardized assessment of patient and family caregiver engagement in research across various contexts. Thank you very much.
Thank you, Cleon.
Before you go, I might also want to acknowledge training support and support from the funders and all our recruitment support. The patients are participants of the study and graphic supports from Shireen and Amrit. And so thank you very much. And
thank you. Okay, time. So first of all, I'd like to thank all our hosts who had presentations, and I really do again apologize. This time was very compressed in order to try and present some really vital information. As a patient partner, I found this very interesting, and I would have liked to have seen everyone's full presentation. So again, if you can leave any links that you would like on the chat line so that we can follow up further. So my thanks to Cleon, Anita, Eileen, Aaron, Iva, Jasmine, Jennifer, Ms. Chen, Linda, and Shannon. And if I've missed anyone, I do apologize. So in closing, first of all, I would just like to say it's really all the time we have for today. A sincere thank you to everyone for contributing, first of all, to putting patients first, 20, because this is really what this work is about, the research with and for patients. We'll reconvene at 3:30, so you now have about a 5-minute stretch. We will reconvene in the plenary room for the final panel on patient-oriented research and health technology, and then our official conference closing. So remember, get up and stretch, hydrate, and enjoy the balance of your conference, and have a good evening. Thank you all.